Let me introduce our first keynote speaker. Dr. Jessie Mbwambo is a senior medical specialist, psychiatrist, and senior researcher at Muhimbili Hospital in Dar es Salaam, Tanzania. Dr. Mbwambo holds a medical degree from the University of Dar es Salaam and her diploma in psychiatry from the University of Manchester, Victoria. In 2005, she served as the head of the Tanzania research team member for the WHO multi-country study on women's health and domestic violence against women. Dr. Mbwambo's research and expertise focuses on HIV intervention and prevention in youth and adults, as well as the relationship between HIV and violence against women. As an expert in IPV and HIV, Dr. Mbwambo served as a valuable member of the planning committee for this workshop. Karibu, Jessie.
Asante sana. That was a very kind of you for such a great introduction. Let me just go back to what Jackie Campbell said, that we started having a relationship, a working relationship, when we were doing the WHO multi-country study. Actually not. We started off with Susan Maman in 1999. How could we forget that? When we were looking at HIV, violence and its implication for HIV testing and counseling. However, my task today is different, is one that we need to be looking at the magnitude of intimate partner violence in Uganda, Kenya, and Tanzania. What is known, what needs to be known to better mitigate and prevent it. I'm sorry for the typographic error. And the way I'm going to go about the presentation is talk about, not talk about, but skip what intimate partner violence is, because that is something that I think everybody knows in this room. That is why we're here. The magnitude of intimate partner violence, risk factors for intimate partner violence, prevention of intimate partner violence, and why prevent intimate partner violence. I'm going to try as much as possible not to make it a scholastic presentation so that we can all engage, and leave that part to the people coming in the next panel who are going to be talking about the academic side or the researching side of it. And I need to say here, it was very difficult for me to really wrap up and try and make sense as to how to make this presentation, taking into account that I know the work of most of the people who are in the presentations throughout the 2 days. I roughly know what they're going to say, and I think if I present to great depth, I'll be preempting what they are going to be telling us. So I'll try and avoid that as much as possible and just agitate the process so that we know where we're going, and people then can present their work. Let me start off by saying one of the largest studies in the world thus far, in which the same methodology was used, we did the same things, was the WHO multi-country study. Tanzania was lucky to be one of the countries that this work was done. However, the two other African countries which were involved, one which was Namibia and the other one which was Ethiopia. In these two other countries, the work was only done in one site. But in Tanzania, the work was done in two sites, one which was in Dar es Salaam, and the other one which was in a provincial region, which was Mbeya. Mbeya, until very recently, had the highest HIV prevalence in the country. And when you look at this study, which looks at ever physical violence, ever physical violence, which is the purple, ever sexual violence, which is the red, and ever physical or sexual violence, or both. We kind of see that when you look at ever physical, sexual violence, or both, you find that people from provincial sites or rural sites have a higher prevalence overall of intimate partner violence. This is telling, and it is something that is seen all along when you look at intimate partner violence in the region. Whether it is a large study, whether it's a small study, the results are the same. It is not only the case when you look at African studies, it is also the case when you look at studies elsewhere, that there is, oh my God, I did something wrong. Right, thank you. It is not only this study, it's not only this part of the study which is showing you something like that, but it is what is recurring in all the sites that they had a city and they had a provincial site. Where you find that the differences are that glaring. This study is a very old study. We need to start thinking of doing other studies like this, but there is a problem. Because if you look at the cost that is involved in doing this bigger study, we're not able to summon the amount of money. However, we have opportunities to be looking at risk factors, and we need to harvest this data, however old it is, to try and look at what are the risk factors associated with violence. What happens? What precipitates it? What happens when violence occurs? The study, which has 55,000 women, offers an opportunity for us to be able to do secondary analysis. Secondary analysis also needs money, and we need to start thinking of where is it we're going to get that money to be able to reharvest the information that we have. We do not know the causal pathways. We can hypothesize, but we need to be in a position where once we know what the causal pathways are, then we can address ourselves to the challenges of how we are going to be working in interventions to be able to get good results that are going to make sure that the prevalence of intimate partner violence and its negative impact on health are felt. So, in Africa, we have looked for an alternative that is going to give us results, at least in as far as looking at a small section of questions that relate to violence. And what we're trying to do is looking at demographic and health surveys and to look at small studies and see whether those small studies are able to give us results that can then be used to intervene and maybe to suggest how we can go to scale, especially when you do a meta-analysis or you look at a systematic review of studies and you see similar occurring situations. Let me just go through the demographic health survey so that I do not preempt the scientific pieces. And I would be very cautious about looking at the outcome of the studies from the Ugandan DHS. One of the things that we saw in this study is that it looks at men and women between ages 15 and 49. So it mixed us a little bit in trying to make sense what is happening, especially because when we looked at it, we actually saw even men were affected, and they were affected by their partners. So what is it that we need to learn from that study? We know there is retaliation, but is this only retaliation, or is it a little bit more than retaliation? So, much as we want to say, okay, it is making us worried, But what is striking, I think, for us is that even when you're looking at men and women through the DHS, still it's the women who are highly affected compared to the men. I am not disregarding the fact that men are affected in this study. I'm just saying that in this regard, I still see 68% versus 24, 93% versus 39 of 40 of men and women are disproportionately affected. Let's look at the women only, which is what they did next. When you look at the women only, what you find is when you look at any form of physical violence, because using the CTS scale, you have quite a number of questions that you ask. You find that 42% of women have had current spousal violence. And when you look at sexual, any form, it is 27.3. When you look at emotional, any form, it is 42.9%. I'd like to caution people here, though, that when we talk about spousal violence, it is not the same as the definition that was used in the WHO multi-country study when we said ever partnered women. Ever spousal violence shows you there is a higher rate than the current partner violence in all of the three domains. Let's look at the Kenyan study. I think the Kenyan study said, the Kenyan DSS said, there's something here we don't understand, and if we put the men here, it's making it a little bit worrisome. Let's focus on the women. And they had quite a large number of women in their cohort. What we are finding here is 41% of women had either physical or sexual, spousal or partner violence. I need to emphasize spousal or partner because of the differential definitions that we have. 13% had either or physical or sexual violence. 48% had either physical, sexual, or emotional spousal or partner violence, and 10.5% had either of the three. This is not small numbers. If it was any other disease that we're talking about, 40%, 10%, would be running and making sure that we're looking for a solution. Let's look at the Tanzanian information. The Tanzanian the Tanzanian information, which has 1,500 women or thereabout, shows almost a similar situation, a higher rate of either or, and an even higher rate of emotional, meaning that there is a higher emotional violence in this cohort. But when you look at either of them, the rates are not very dissimilar. When we look at emotional, because it is a little bit confusing as to what does it mean, we try to look for proxies. And in the proxies, we find that when you look at all the three DHS studies that were done, there are at least 3 controlling behaviors associated with intimate partner violence. At least 3. But what was mentioned more in this study, in the 3 countries, is women talk to other men, partner wanted to know where woman was at all times, partner accused woman of being unfaithful, and partner was not permitting woman to meet her friends, her female friends. And this is across the whole continuum. And we know if there is controlling behavior, women present with higher prevalence of intimate partner violence. But the other situations that have not come out as strongly, which have been seen in the DHS and the WHO study. And these are women not being allowed to make their own decisions, women not allowed to spend money without permission, women not allowed to visit natal relatives, and threats of violence to people woman loves. These are what we call emotional. They're trying to make use of certain situation that make sure that the woman conforms. If she doesn't, she gets subject to intimate partner violence. I like this picture, and I think I would like to show that to you, because this is a small study, but it is echoing exactly what we've seen with the 55,000 women. It is also echoing information coming out of enumeration units from the DHS, which is telling us that even in smaller studies, there's certain things which are positive without much difficulty. And this is a small study that is currently ongoing in Tanzania, which is led by Futures Policy Project, and we're working together. How fascinating. So, why are women subject to partner violence? Wow. Well, we're being told because intimate partner violence is a private matter. Nobody should intervene. This is cultural. It has always been the case. So, even if it so happens, and even if there are laws, you can't do anything, because it is our culture. Women are in a situation where they are disempowered as women because of the male dominance. This is part of what is called the cultural norm for most of the communities. Women is also entitled to be punished if she does something wrong. So if a woman really feels that if she does something wrong, she has to be punished, then it is going to be very difficult for you to be talking anything to her. And this is another really fascinating diagram which shows you that however you look at it, whether it is the DHS, whether it's the WHO big study, whether it's the community, you still have things like, I deserve to be beaten. She should tolerate being beaten because of the family. She should be beaten if she's unfaithful. She should be beaten if she won't have sex with a man. She should be beaten and insulted if she puts the reputation of the family at stake. And it's a private matter. Whatever we do, we just come back to the same situation. And when you look at these situations, they're very male-oriented. I'm not bashing the men here. Actually, I did acknowledge earlier on that I'm so happy that for the first time, I'm getting into a meeting where close to about 40% of the people in the meeting are men. This was not the case in the year 2000. Okay? And then we look at what is it that a woman has to do. And all these things that a woman has to do mean that if she hasn't done them correctly, for instance, you cook food, doesn't have salt. You cook food, it gets burnt. The partner walks in, the house is dirty. The kid has a dirty nappy. The husband walks in, you're sick in bed, and you haven't done what you are expected to do, you deserve to be beaten. Because a woman does not deserve to take a rest from her roles and responsibilities. What is very worrying, and this is not only as we talk about the women themselves and their tolerance, but even amongst men, even amongst elitists, is the tolerance towards gender-based violence. And because of that, women are not expected to live out of their marital home. First of all, you go back to your parents, and your parents tell you, go back. You cannot come to us. You're a married woman. How do you think we have come thus far? Meaning we have tolerated violence. And then you're being told, so what happens to your children if you leave? Because children belong to the husband's family. So if you're leaving, you need to leave the children behind. And then what will happen to the marriage? Because we had all this big ceremony, and we're all very into, keep it together, keep it at home, and all of a sudden, you say you want to leave. You will not be allowed to leave. And unfortunately, some of the custodians of these cultures are the women themselves. So women here become their own worst enemies. We also know that women are not moving out of their home because of their financial standing. Women are poor. Women fear leaving their marital home because they do not know how they will survive. So they tolerate the negative consequences because they're dependent on their male partners. Women may be subject to negative experiences, but they do not get screened, so they do not get diagnosed, so they do not get treated early enough. Not only are we saying the difficulties in the general population, but even within the healthcare system, there is a problem, and we need to be able to address that. So what do we need to do and why? I do not have the statistics. I know somebody worked with something called an econometric model, not in Africa, and they're saying the cost of gender-based violence is very high. The cost of intimate partner violence is something that we need to be paying attention. But we haven't done anything in the region to say we need to do something. We know, for instance, community interventions work, but we know that they work in small areas. We have not been courageous enough, and we have not been able to convince governments to make sure that they take them to scale so that we have a larger coverage, so that we have a larger reach. We have not done studies that allow us to say, this actually works. But in the small studies that have been done, there is evidence that intervening actually does work and does reduce HIV incidence. Capacity building in terms of human resource and infrastructures. What we're doing is we're wanting to start a lot of things that need to be done before we're really ready. We want to run before we're ready. We have gender desks. The gender desks have everybody still listening on what is it this person is saying. We don't have enough consulting rooms that allow for women to go through a private process. We need to make sure that happens, and then look at what is the cost of making sure that happens and that the women are able to follow through and the community is able to follow through, and that we change the HIV or hepatitis prevalence of the women. Oops. We have policies, and we have some laws, but I'm here to sit and hear where a policy and a law was fought out in a situation where, I'm not saying a woman of my stature, a woman from the village, worked through the system and it worked. We need to go through that system and make sure that we track that system, we cost that system, and we're able then to say, what is it if we do that for all the women in need? Mind you, we have 40% of women who are subject to violence. Safe exit plans and places. This is an infrastructural issue. It would have been one of the great situations to be able to work with. We know it works elsewhere, but we don't know what it means if we have to work with that in Africa, especially in our immediate region. Engagement of men. Men are custodians of culture. Men have not been engaged. Women have been talking alone. And we know if women talk alone in our region without engaging the men, nothing moves. So the two studies that have been, two interventions actually, that have been working on this, and I think they will be part of this, this meeting. They will be talking to us about it. One is Men Engage, that is happening in Tanzania. I don't know if there's anybody who's going to be talking about that. But the other one is Men Engage. And I'm looking forward to hearing what they're going to tell us about that, because it will be really useful to be able to take those and go up to scale. Screening and giving people care. I know a lot of us have started doing that. I know WHO is not particularly happy with this one based on the review that has been done, but we are in countries where the HIV prevalence is high, hepatitis prevalence is high. Could we be dealing with different populations? Can we put in interventions and then follow through and see what it is that this means for the East African region? I would call for research for each of these models and cost the interventions that we're going to be able to put to try and see if we're going to be able to reduce HIV and hepatitis, especially among young women, and more so those subject, and more so because they are the ones who are subject to intimate partner violence than the rest of the general population. May I present? Thank you.
Thank you very much, Jessie. Thank you very much for a very, very well researched presentation. I think it turned out nicely that we started with Dr. Mbwambo, because she set the stage for demonstrating that there is a problem, the scope, and also reflecting on the drivers. And I think that that presents an opportunity for us now to engage, to move to the next level of saying there is a problem, and therefore there is a need for policy, there is a need for program, there is a need for researching more about the areas that she has mentioned. I think she's also made a very good comment, especially for our policymakers, that IPV comes with a great cost, not only to women's health, but I think to the healthcare system of the country. I know that parliamentarians are only convinced if there is a cost, and Jessie has demonstrated that there is a cost, and so it's something that we need to seriously reflect on.